Good time, everyone. I am Hadi Miskin from University of Pisha. I am presenting this interactive lecture about gestational diabetes mellitus. The content of this lecture is suitable for the 30 years medical student. The specific learning outcome of these interactive lectures, and so by the end of these sessions, we'll be able to define gestational diabetes, describe the natural course and risk factors that contribute to gestational diabetes, list the screenings and diagnostic method in clinical practice, mention the health risk associated with gestational diabetes to mothers and baby, and finally, outline the management strategies employed in gestational diabetes management. Approximately 7% of pregnancy complicated by diabetes, and these either gestational diabetes, which develop during pregnancy, or pre-gestational diabetes mellitus, which is pre-existing to pregnancy. Complicate 3 to 5% of all pregnancy in general, and 90% of these first detected during pregnancy. Pre-gestational diabetes occur in up to 1.4% of all pregnancies, while the gestational diabetes represent 2.5 to 5%. Gestational diabetes can be defined as that is a carbohydrate intolerance of variable severity with onset or first recognition during the present pregnancy. Thus, it includes women with pre-existing but previously unrecognized diabetes. In these diagrams, we can see that diabetes in pregnancy in general can be divided, as mentioned before, gestational diabetes or pre-existing diabetes. For the gestational diabetes, either true gestational diabetes or pre-existing diabetes has been not discovered, while the pre-gestational diabetes either to be type 1 or type 2. The classification of diabetes in pregnancy, it is either, as we mentioned before, either type 1 diabetes mellitus, which is diagnosed in childhood and caused by immunologic destructions of cell of the pancreas, and the common complication can occur is diabetic ketoacidosis. To type 2 diabetes mellitus, it is an adult onset, mostly associated with overweight, weight controls, and carefully follow the diet can be one of the effective interventions. This results from insulin resistance and exhaustion of the pancreatic cells. And 3, gestational diabetes mellitus, glucose intolerance identified during pregnancy. In most patients, it should subside postpartum. So what's the physiology of glucose metabolism in pregnancy? In general, dietary habits frequency changes during pregnancy, as we know that, and the several pregnancy-associated hormones have also a major effect on glucose metabolism. Most notable of this is human placental lactogens, which is produced in abundance by enlarging placenta. The physiological function of human placental lactogen is act as anti-insulinism, affect both fatty acids and glucose metabolism. It promotes lipolysis with increased level of circulating free fatty acids and cause a decrease in glucose uptake. Besides human placental lactogen, there is also other hormone brain play a roles in development of diabetes, or it is involved in metabolism of glucose. These estrogens and progesterone, which interfere with the insulin-glucose relationships. And also we have insulinase, which is produced by the placenta and degenerate insulin to a limit extent. This effect of pregnancy on glucose metabolism makes the management of pregnancy-associated diabetes so difficult. Regarding the clinical features of gestational diabetes, GDM is usually asymptomatic and develop in the second or the third trimesters and induced by inappropriate carbohydrate metabolism and decrease in insulin sensitivity. GDM may be diagnosed by routine biochemical screenings or may be suspected in a case of macrosomic fetus, polyhydramnios, persistent heavy glucosuria, or recurrent infection. Occasionally, GDM may be diagnosed retrospectively with a random plasma glucose or hemoglobin A1C following an intrauterine death or pregnancy or a severely macrosemic infant. GDM is more commonly found in a woman with previously GDM, family history of diabetes, previous large for gestational age infant, obesity, and older age pregnancy. GDM is associated with increased prenatal morbidity and mortality in the same way, but to a much lesser degree than pre-existing diabetes. Unlike pre-existing diabetes, there is no increase in the congenital abnormality rate, except in those women with unrecognized diabetes predating the pregnancy. GDM is associated with increased risk of preeclampsia as general. So, the common features of GDM is firstly occur during pregnancy, and it is usually without symptom and detected by routine screenings in second or third trimester and result in macrosomic or large baby. It affects about 2 to 4% of all pregnancy and can place both mothers and child at risk. So there is a certain groups that has been categorized as high risk risky groups of GDM, like obesity, positive family history, history of delivery of a large baby, history of stillbirth or unexplained neonatal death, history of preeclampsia, chronic hypertension, history of congenital anomalies, and also recurrent urinary tract infections, one of the risk groups, and also women whose age more than 30% and history of polyhydramnios and prematurity. So the effect of diabetes on pregnancy or in pregnant mothers can be categorized as antenatal, intranatals, or postnatals. The antenatals include abortion, preeclampsia, infection, hyperglycemia, preterm labor, malpresentation, diabetic ketoacidosis, hypoglycemia, and worsening nephropathy or retinopathy. And intranatals include CVD, developmental fetus proportions, shoulder dystocia, and increased operative interference. Postnatally, patient may develop postpartum hemorrhage, or they may be traumatic injury or peripheral sepsis. While the effect of diabetes on pregnancy include, regarding the fetus, include congenital anomalies, which is rare in gestational diabetes, macrosomia, IUTR, if the patient develop vasculopathy, and IUFD. In the neonatal period, there may be hypoglycemia, hypocalcemia, hypokalemia, and hypomagnesemia. Also, there is hyperbilirubinemia and hyperphagocytic syndromes, besides respiratory distress syndromes. So the consequences of hyperglycemia during pregnancy is mainly macrosomia is a major problem. It is weight more than 4,000 grams, and most probably it would be associated with shoulder dystocia as a main complication. It's not probably, but it is associated with shoulder dystocia as a complication, and the fetal malformation commonly in pre-gestational diabetes, while macrosomia is commonly in gestational diabetes. Diagnostic screening of GDM is mainly laboratory screenings, confirmations, and the timings. Suitable times to screen for gestational diabetes is 20 to 24 weeks, repeat at 30 weeks. All patients, but in high-risk patients, start early screening. Screening is mainly by oral glucose killing test with 550 milligrams, 1 hour. If it is more than 140, go to GTT, and if it is more than 200 milligram per deciliter, go to the fasting blood glucose. Random blood sugars, when it is more than 100 milligram per deciliter, go to GTT. And glycosylated hemoglobin, which can give retrospective diagnosis. The confirmation is mainly by glucose tolerant test, GTT. Management of diabetes during pregnancy, it is mainly patients with diabetes are monitored closely through pregnancy, and this is usually at 1 to 2 weeks intervals. Pre-gestational type 1 continuing intensive insulin therapy with blood glucose monitoring. Type 2 stop all oral anti-diabetics drugs and start insulins, while in a GTTM, you should start firstly diet controls, start insulin if the diet fails, and human one is preferable. Carefully monitoring and carefully monitors, and those are just especially during the end of pregnancy, labor, and after delivery. Insulin requirement undergoes several changes during this period. So diabetes is a mainstay. Diet is a mainstay of GTM management. Exercise at least 5 to 10 minutes. Insulin, oral anti-diabetics drugs are being used more commonly in treatment of GTM, irrespective to diet controls. And also, in case of metformin, it has been used in many patients with polycystic ovary syndrome, PCO. As with pre-existing diabetes, close collaborations between obstetricians and physicians is so essential to optimize better outcomes, and women should be managed in specialist multidisciplinary diabetes pregnancy clinics. As we mentioned before, exercise is very important in the management of gestational diabetes. Insulins, and we can categorize insulin in based on its source, either human, bovine, or pork. Human is preferables, and either based on their actions, it can be short, intermediate, or long actions. Insulins. As projected here in this slide, this is a target glucose levels in the fastings should be around 60 to 100, 1 hour and 2 hours postprandial, and nocturnal is different from each others. In labor also there is, and hemoglobin A1C also should be adjusted as normal. The monitoring merely for the mothers is by full blood glucose and postprandial blood sugars weekly. Is preferable for the fetus. Congenital anomalies, we should screen for congenital anomalies, and the fetal well-being also by ultrasounds, and the fetal growth, we should to monitor the growth to predict macrosomia. GDM usually recur in subsequent pregnancy, and sometimes if a woman has lost a lot of weight between pregnancies and modified her diet substantially, she may not develop GDM. So lifestyle after pregnancy is very important, especially in patients with GDM. Women should be advised of the risk of recurrent GDM and future type 2 diabetes, so to be very careful in dealing with her situations. Adequate contraception and pre-pregnancy counseling is important, and women with previous GDM should have fasting blood glucose checked prior to conceptions to detect diabetes that may have developed since the last pregnancy. There is some point you have to remember when dealing with a patient with gestational diabetes. The prevalence of GTP depends on ethnicity and the criteria used for the diagnosis. Ethnic minorities are at increased risk. The importance of diagnosing GTM related to the high risk of future diabetes, the detection of pre-existing diabetes, and a risk of macrosomia and adverse pregnancy outcomes. The associations between maternal hyperglycemia and adverse outcomes is linear with no threshold criteria for diagnosis are not currently based on the post-utility analysis. Treatment of GTM reduce birth weight and adverse prenatal outcomes, and the management of GTM is with diet, exercise in the first instance, followed by oral hypoglycemic agent, and then insulin in the resistant cases. Pregnancy and the puerperium provide a unique opportunity for education regarding lifestyles and dietary changes. We can conclude that preventive medicine starts before pregnancy, and we advise every woman to receive preconception care. Thank you very much for listening, and we are so very happy to receive your feedbacks in these tubes, and highly welcome for any question or explanation. Thank you very much.